The following podcast is part of a certified educational activity titled Meeting Therapeutic Challenges in Pediatric ALL, Expert Perspectives on the Use of Asparaginase Compounds. Access the entire activity and complete the post-test at peerview.com/ZBG860. Downloadable slides and practice aids are also available.
Hello and welcome to today's meeting on the use of asparaginase compounds. I'm Dr. Elizabeth Rates from NYU Langone in New York City, and I'm pleased to welcome my colleague, Dr. Rachel Rao from the Baylor College of Medicine in Texas. So for today's agenda, we're going to begin with an introduction on where we stand with asparaginase therapy in pediatric ALL, and then we're going to shift to a case discussion on asparaginase therapy, which will really highlight the principles of care, treatment barriers, as well as next steps. So I'd like to begin with a historical perspective. So back in 1953, Kidd and colleagues actually described the application of guinea pig serum to lymphomas in mice and rats, and they saw that there was significant regression in the disease burden, but it was unclear what element of guinea pig serum actually was responsible for mediating that effect. Then a publication from Broom and colleagues in Nature in 1961 actually showed and provided evidence that it was L-asparaginase activity, and that was the element of guinea pig serum that's responsible for the anti-lymphoma effects. If we move next to 1966, this was the first time when a child was treated with L-asparaginase. So this was a boy that had been diagnosed, he was 8 years old. He had been diagnosed 3 years previously with ALL and was refractory to all different treatments. He received an asparaginase infusion intravenously over 6 hours, and in the week to follow had a decrease in his white blood cell count, a decrease in his peripheral blast count, and a significant reduction in his extramedullary disease burden. Since the 1970s, asparaginase has been a cornerstone of ALL treatment, but unfortunately it has to be discontinued in up to 25% of patients because of unique toxicities. Pegylated E. coli asparaginase, or PEG-asparaginase, is the most commonly used first-line formulation in high-income countries. Erwinia chrysanthemi asparaginase substitution was approved in 2011 for hypersensitivity to PEG-asparaginase, and now this is a standard of care. It's very interesting that 50 years later, we're still working on some of the same issues in optimizing efficacy and minimizing toxicity. This slide summarizes the currently commercially available FDA-approved asparaginase preparations. Of note, native E. coli asparaginase is also FDA-approved, but that's no longer available in the United States. So there's two pegylated E. coli preparations, PEG-asparaginase and CalPEG. They differ in terms of their linker, so it's a little more stable linker with the asparaginase product. You can see that this then relates to differences in their half-life. So PEG-asparaginase, the half-life for the intravenous administration is 5.3 days, 5.8 days when it's administered intramuscularly, whereas CalPEG has a much longer half-life of 16.1 days. In terms of the FDA-approved pediatric dosing in individuals less than 21 years of age, for PEG-asparaginase, it's 2,500 units, international units per meter squared, no more frequently than 14 days. And similarly for CalPEG, but here the interval is 21 days due to the longer half-life. And then for PEG-asparaginase, actually for individuals 21 years of age or greater, the FDA-approved dose is actually 2,000 international units per meter squared rather than 2,500. Again, no more frequently than every 14 days. Of note, CalPEG is not approved for individuals 21 years of age or older at the present time. If we switch to Erwinia, this has a much shorter half-life, particularly when administered intravenously. It's a 7.5-hour half-life. For the IM mode of administration, it's a 16-hour half-life. The FDA-approved dose is 2,500 international units per meter squared on a Monday, Wednesday, Friday schedule for 6 doses for each dose of PEG-asparaginase, and this is approved for both children and adults with the same dose. There's currently investigational asparaginase product that's being studied. So JZP458 or RCP is a recombinant Erwinia asparaginase produced in Pseudomonas fluorescens. So it's a non-E. coli derived product. RCP is intended for use as a component of a multi-agent chemotherapeutic regimen for the treatment of patients with ALL and lymphoblastic lymphoma who have developed hypersensitivity to an E. coli derived asparaginase. JZP458 was granted Fast Track designation by the US FDA in October of 2019, and there's an open label trial. This is COG AALL 1931 and JZP 548201 that is currently ongoing in enrolling patients. So looking back historically, there have been several lines of evidence that have showed that intensified asparaginase delivery improves clinical treatment outcomes. So this is a summary of 7 different trials, and you can see that the regimens that incorporated more intensive asparaginase schedules compared to less intensive asparaginase schedules led to significant improvements in event-free survival. More recently, Sumit Gupta and colleagues looked at the impact of asparaginase discontinuation and Erwinia substitution in children with B-ALL who were treated on NCI standard risk and high risk trials. And key findings from the study was that substituting Erwinia asparaginase for pegylated asparaginase did not have any adverse impact on outcome. And you can see that in looking at the curves on the right, really identical disease-free survival if Erwinia was able to be substituted for doses of peg asparaginase. However, when peg asparaginase was completely discontinued, there was a 50% increased risk of an event among the high-risk patients, and you can see a significant decline in disease-free survival when there wasn't complete substitution with Erwinia asparaginase. So there's some challenges in asparaginase delivery that we all are facing. One is drug shortages, and the other is the very unique toxicity profiles that are observed with this agent. So Erwinia asparaginase has been globally in short supply for quite some time, which has impacted negatively the ability to consistently have access and deliver this drug. And asparaginase has some very unique toxicities, the most common of which are hypersensitivity reactions, depending on the formulation and the definition of those reactions, which can occur in up to 30% of patients. Pancreatitis occurs in 5 to 10% of individuals, hyperglycemia in about 4 to 20%, hepatotoxicity, grade 3 to 4 toxicity specifically, in less than 10% of children, but certainly much higher in the adult population, and thrombosis with an incidence of about 2 to 7%. So we wanted to shift now and move to more of a case-based format to highlight some of the issues that we are facing in the delivery of asparaginase and some of the solutions. So we're going to begin with the presentation of Robert, a 17-year-old male with a BMI of 37, which is at the 99th percentile, who's diagnosed with PH-like B-ALL. He begins a standard 4-drug induction regimen, and I think some relevant questions that come up at our center and many others is this patient at heightened risk for asparaginase-related toxicity, and should dose capping be considered? And I wanted to turn it over to you, Rachel, to hear your thoughts on these questions and how you're approaching this at your center.
Thank you, Elizabeth. That was a fantastic introduction to this topic. Certainly, at Texas Children's, we see a number of AYA patients, many of whom are in the obese category. And we do have concern for the unique toxicities of that particular population of patients and have some institutional experience that suggests that patients who are obese are indeed at increased risk for hepatotoxicity in particular. So we do have concerns about this particular group of patients. We have not yet implemented dose capping of asparaginase. We are traditionally an institution that follows COG guidance, and up to very recently, COG's protocols did not allow for dose capping of asparaginases. However, I think with increasing data that suggests this really is a group of unique toxicity profile, and the allowance for dose capping on COG studies will ultimately make that change. So we do have concern, and I think this group of patients do warrant some special considerations when it comes to the appropriate dose for them. I'm not sure what your experience has been and what you're doing at NYU, Elizabeth, but I'd like to hear your thoughts as well.
Yeah, we approach it similarly. Like, we have always adhered to the COG guidelines, which, as you stated, didn't allow for dose capping previously, but we've certainly seen the same pattern of heightened risk for toxicity in some of our AYA patients and patients with obesity. And in talking with our adult colleagues, they really have, noticed that when they cap the dose or give a lesser dose, that has really helped their patients in terms of the hepatotoxicity in particular that they have observed. So I think now that the COG guidelines have been modified to allow dose capping in selected situations, we're really going to adopt that approach as well. So just to touch upon these points with some recent publications, there has been concern that's been raised with the heightened risk for toxicity in certain patients, and particularly those with high body surface area. And in looking at some of the data on the impact of BMI on the toxicity profile, Rachel, this is actually a publication from your institution, review of patients, and you can see that there was a significant association with significant conjugated hyperbilirubinemia. So this was defined as grade 4 hyperbilirubinemia in those individuals with a BMI that exceeded the 95th percentile. There was a similar publication from the group at the Children's Hospital of Los Angeles, where they too looked at the impact of BMI and also on age on toxicity profiles, and they found a significant increase in the risk for severe hepatotoxicity and clinical pancreatitis in those individuals who were at least 10 years of age and also had obesity. And here they define severe hepatotoxicity as grade 4 transaminase elevation or grade 3 hyperbilirubinemia. Their definition of clinical pancreatitis followed the consensus guidelines from the Ponte de Legno group that for the most part in those cases. So I think these data really highlight the risk that exists in this patient population. And then the impact of dose on toxicity profiles. So certainly the adults have found that with higher doses of pegasparaginase, that has been correlated with a heightened risk for toxicity, particularly hepatotoxicity, as we've mentioned. I think in the pediatric population, this has been less clear, but this is actually a retrospective analysis from a pediatric center where you could see that there was a statistically significant increase in the risk of venous thrombotic events, pancreatitis, and hyperglycemia when children received greater than 3750 units for their pegasparaginase dose, which is a vial size. So as we alluded to, the Children's Oncology Group recently modified their asparaginase dosing modifications to address some of these concerns that have been raised, and as well as to be in line with the FDA label. So patients less than 21 years of age will continue to receive the FDA-approved dose, the 2,500 unit per meter squared dose. To match the label, now individuals who are greater than 21 years of age will receive the 2,000 unit per meter squared dose. And obesity, which I think we've tried to highlight, has been linked to an increased risk for toxicity in patients, particularly those who are at least 10 years of age. There will be dose capping at a 3750 unit per dose and one vial size that is allowed per institutional policy in cases where there is baseline obesity. So back to our case. So Robert receives a capped dose of pegasparaginase on day 4 of induction after premedication, and his asparaginase activity level on day 11, so 7 days later, is very therapeutic. It's 0.607 units per mil. On day 20 of induction, he develops a persistent throbbing headache and nausea. This persisted despite treatment with routine analgesics, and this prompted an MRI-MRV that showed a sagittal sinus thrombosis. So Rachel, I just wanted to turn it back to you. So how would you manage this type of thrombosis acutely and in the long term? And when or if would you consider resuming pegasparaginase?
Yeah, so certainly this is one of the toxicity we see that perhaps raises the physician's blood pressure the most. It's a very alarming presentation oftentimes. And for this patient, we would admit them to the hospital and initiate emergent anticoagulant therapy, and then follow their symptomatology very closely. Ultimately, we want to establish them on a persistent anticoagulant regimen, and for us, that's Lovenox until we achieve therapeutic levels. As far as the consideration for resumption of peg asparaginase in this particular patient, we know this child needs his asparaginase to make sure that we maintain the best possible outcome for him, and so we certainly would push to do that safely, and we would follow symptomatology, so we wouldn't consider doing that until his symptoms had fully resolved and he was on a very stable anticoagulant regimen. I think we, and perhaps you as well, also can use imaging to guide those decisions. By imaging, we would want to see that clot has certainly stabilized and hopefully begun to resolve or improve before we would consider rechallenging this particular patient with peg asparaginase. That's sort of our generalized approach. Interested in your thoughts as well.
I think we would manage a patient like this similarly, and I agree. This is one of the types of situations that really is very anxiety-producing for everyone. We would definitely admit the child to the hospital and would therapeutically anticoagulate, and enoxaparin is our first-line choice as well. We found that sometimes it's hard to achieve a therapeutic level, so we follow AT3 levels pretty consistently, and often in a situation like this, so close to asparaginase, would need to replete antithrombin 3 to achieve an optimal therapeutic effect with enoxaparin. And we would, again, follow symptomatology very closely, would re-image before considering, resuming peg asparaginase, but certainly would agree that in a situation like this, the benefits we would assume would outweigh the risks as long as the child improved and all symptoms resolved and showed stabilization or improvement in the clot and imaging studies. We always debate how long to treat in a situation like this. You find there's different published guidelines on that, but in general, I think for our group, we would want to continue therapeutic anticoagulation until this patient had completed all of their scheduled asparaginase therapy, just for concern that there would be heightened risk with re-exposures. Okay, we'll move on here. So just a few words about thrombosis. So the overall incidence in children receiving peg asparaginase or asparaginase formulations is about 3 to 5%. Most incidents occur during induction. It's much more common in older children and adolescents, and there has been some differences that have been noted in the hemostatic protein profiles in older children. The risk appears to be similar with the different types of asparaginase preparations, and most often it's possible to resume asparaginase after symptom resolution, clot stabilization or improvement, and effective anticoagulation. And now, Rachel, I'll turn it over to you.
Thank you, Elizabeth. So we've discussed certainly the importance of asparaginase in ALL therapy for our patients, and now we'll sort of transition into ways that we can ensure consistent, persistent, and effective asparaginase therapy. So going back to Robert, he's now reached consolidation, and he's day 15 of consolidation, so receives a dose of peg asparaginase by IV infusion. About 10 minutes in, he starts complaining of not feeling well, is nauseated, and the nurse notes that he's got some mild flushing that's diffuse. So I'll turn it over to you, Elizabeth. This certainly is a relatively common situation. What's your management approach?
I think these are tough situations, because the million-dollar question is whether this is a true hypersensitivity reaction or infusion reaction, and I think it can be sometimes really hard early on to tell. In a situation like this, where the symptoms are still subtle, and assuming the patient is doing well, so vital signs are normal, doesn't really have any urticaria or angioedema or respiratory distress, we would consider this probably more likely to be an infusion reaction. And in an effort to get the peg asparaginase dose in, we would pause infusion. We pre-medicate everyone as a routine, so pre-meds would already be on board, and then we would wait and just monitor closely. And if the symptoms improved, then we would restart the infusion, but at a slower rate. So rather than planned infusion time over an hour, we would extend it so the drug would be planned to go in and administered over 2 hours instead. Rachel, what would you do at your center?
Yeah, we likewise have also implemented universal premedication for all of our Peg-Asparaginase doses. So presumably this child would have received those. Certainly we look back and make sure they were given with enough time between that dosing and the initiation of infusion to maximize their efficacy. And we like to allow an hour between our premedication and when we initiate the infusion. But presuming all those things were done appropriately, we would likewise pause the infusion, allow him some time to recover, make sure the flushing had resolved and he was clinically stable, and then resume at a half the rate that we had been running the drug previously. And provided he's tolerating that well, we could consider re-increasing back to the dose we had started on after some time of stability. But it's all dependent on how clinically he's doing.
I think I forgot to mention too, important is we, with our premedication, have implemented routine therapeutic drug monitoring. And so in a situation like this, it would be important, to make sure that it wasn't a masked hypersensitivity reaction and really achieved a therapeutic level. Do you do the same at your center?
Yeah, for our patients, now that we've implemented our premedication strategy, we do follow levels to ensure that we haven't masked a true antibody-mediated hypersensitivity reaction. And certainly for a child who's had, even a questionable reaction, I think that would be of critical importance to make sure they're achieving good therapeutic levels with the dose that they received. Great. Thank you for those thoughts, Elizabeth. So going on to a little bit of information about hypersensitivity reactions. Because asparaginase is a foreign-derived protein, it's manufactured by bacteria, it can provoke an immune response. Our body is set up to mount an immune response to anything it deems as foreign, and asparaginase is subject to that immune response. Now, in many cases, the hypersensitivity is manifest as clinically by anaphylaxis or an allergy. So patients have angioedema, hives, and pretty dramatic presentation of their symptomatology. These hypersensitivity reactions historically with asparaginases have been associated with immune destruction of the asparaginase. Certainly those antibodies can bind and destroy the antibody, can bind and destroy the asparaginase, and therefore you lose therapeutic efficacy. And these are termed in the literature neutralizing antibodies. They neutralize the effect of the drug. We have a fair amount of data about what percentage of patients will develop true hypersensitivity reactions. Initially before the advent of pegylated E. coli asparaginase, we used native E. coli asparaginase. And the reports vary pretty widely, but up to 60% of patients exposed to native E. coli asparaginase had hypersensitivity reactions. Interestingly, it was reported that the occurrence of this was lessened when the asparaginase was given during phases of corticosteroids, so aligned with a suppression of the immune response. Of course, nowadays, we use pegylated E. coli asparaginase as our primary preparation, and this is because of the pegylation of that asparaginase is less immunogenic than the native form. Of course, we still do see hypersensitivity reactions, even with pegylated E. coli asparaginase. But again, the reports are pretty broad in terms of what the rates have been seen in the literature. A CCG study was one of the first to sort of look at what was the occurrence and incidence of hypersensitivity with PEG asparaginase. And they reported when PEG was given via IM administration that about 3% of patients had a clinical allergy. Dana-Farber, of course, uses a much more intensive asparaginase regimen compared to COG studies. They'll give continuous asparaginase over up to 30 weeks of the patient's therapy. And with that more intensive asparaginase-based regimen, they do tend to see higher rates of hypersensitivity in their patient population. And this nice paper published several years ago by Louis Silverman documented about 15% of their patients given IM PEG asparaginase had hypersensitivity reactions. Now, those two studies comment only on the rates of hypersensitivity reaction after PEG asparaginase has been administered by intramuscular administration, and that really was the standard of care when PEG asparaginase was first brought to the market. Back when I was a fellow, it was sort of a transition time between when patients were getting IM PEG asparaginase to when we were administering it now by IV infusion. And I think that was first with the AALL 0331 and 0232 series of COG studies that transition occurred. And I very vividly remember being a fellow and thinking that and very, very rarely seeing any allergic reactions to peg asparaginase. And then when we started administering it via IV infusion, everyone was sort of on heightened awareness because I felt like we were seeing it, in one of every 4 or 5 patients. And there was a study, a single center study that was having the same sense of the difference between IM and IV administration of peg asparaginase, and so looked at their population of patients and found that when they were administering it via IM route of administration, about 10% of their patients were having hypersensitivity reactions. But when they switched to IV, they were noting reactions in about 36% of their patients. So somewhat an alarming increase in the frequency of allergic reactions. Now, I think what sort of put me and I think a lot of people at ease was data presented by Mike Burke from the Children's Oncology Group. Mike and his colleagues looked back at the last 6 Children's Oncology Group studies, which included over 16,000 patients and over 50,000 doses of peg asparaginase. And that was really a split between administration by IM and IV routes of administration. And when they looked at the rates of grade 3 or greater hypersensitivity reactions, it was quite reassuring. Only about 5% of the patients who got it via IM and about 3% of the patients who got it via IV routes had hypersensitivity reactions that were grade 3 or greater. I think the study was also important in noting sort of the expected timing of these true hypersensitivity reactions. The vast majority of these occurred with either the second or third dose the patient received. So I think that can be helpful information when you're trying to distinguish if a patient's reaction is an infusion versus a true antibody-mediated hypersensitivity reaction. So what's sort of complicating the picture? Elizabeth already alluded to this. It's really hard to sort out what's a true antibody-mediated hypersensitivity reaction and an infusion reaction. And just broadly speaking, the definition of an infusion reaction is a reaction that develops during or shortly after IV infusion of a medication. And certainly this is not exclusive to peg asparaginase. There are a number of medications that when given by an IV route can lead to an infusion reaction. And these are thought caused mostly by release of cytokines or histamine. Some have documented direct activation of the complement system as the mechanism that caused these reactions. And then something that is potentially unique to asparaginase is this sharp elevation of ammonia levels. And you can see in the formula down below, that's because of the direct mechanism of activity of asparaginase is to cleave asparagine, an amino acid, into 2 breakdown products. One is L-aspartic acid, and the other is ammonia. And so you can imagine if the body has relatively high levels of L-asparagine in the system, at the time of administration of L-asparaginase, you rapidly break that down with a rapid release of ammonia, and therefore the levels build up quite quickly in the body, and that can lead to a lot of the symptomatology that we see in patients receiving IV infusions of asparaginase. So when faced with a patient in clinic, it's always really challenging, and in the heat of the moment, it can be almost impossible to sort through what's a hypersensitivity reaction that's mediated by those neutralizing antibodies versus what's just an infusion reaction that you can potentially safely push through. And again, Mike Burke's paper, as well as a number of other studies, have demonstrated that the timing maybe can help. Those antibody-mediated reactions are most likely to occur with the second and third doses. So for COG studies, those are the consolidation doses. And infusion reactions, on the other hand, are more commonly seen with the first exposure, with increased exposure leading to decreased risk of infusion reaction. Now neither of those are 100%, because certainly we can see those antibody-mediated reactions with other doses, and infusion reactions can occur with a second or third dose. So it's not a foolproof way to determine which is a hypersensitivity versus an infusion reaction. The signs and symptoms can help, but they're really challenging, especially in somewhat of an emergency situation, to distinguish because a lot of the symptomatologies are largely overlapping. And I'll discuss that a little bit more on the next slide. And then lastly, those serum asparaginase activity levels can provide some objective data of if there are antibodies present that led to the destruction of your asparaginase. So that can be one piece of information that's critical really in distinguishing hypersensitivity versus infusion reaction. So this is a nice table published by a group of nurses in the Clinical Journal of Oncology Nursing. And certainly nurses are on the front line of these reactions. I think they're well positioned to help us distinguish hypersensitivity versus infusion reaction. But as we've stated, the problem is that a lot of the symptoms fall onto both columns of this list. And so there may be a few that can help you sort of sort out in the heat of the moment which is which, but not too many. I'll just point out a few here. So headache is more commonly seen in infusion reactions. As far as the skin manifestation, an antibody-mediated reaction would more likely have angioedema, hives, or urticarial reaction, whereas the infusion reaction is more like what our patient had, that sort of diffuse flushing, whole body erythema that might point you towards an infusion reaction rather than an antibody-mediated process. And then dyspnea, if it's not accompanied by other respiratory symptoms, so there's no chest pain, no hypoxemia, no tightness of the chest or other respiratory features, then that might be more associated with an infusion reaction. But again, none of these things are 100% exclusive of one or the other. And then lastly, the use of serum asparaginase activity, I think, can be incredibly helpful in really, really clearly sorting out, is this antibody-mediated or not? And while the best data we have is really expert-level opinion in this paper published by Archie Blyer and his colleagues a few years ago, that I still rely upon today to help guide my decision-making in terms of use of asparaginase activity levels after a reaction. So what Archie and colleagues laid out is that if a patient has received less than 10% of the dose, the asparaginase activity level probably isn't going to be incredibly informative, because with that small amount of the drug given, you would expect those levels to be low. So it wouldn't really help you sort out if this was an antibody-mediated process or just having the patient gotten a very small amount of the drug. If, on the other hand, you managed to get 10 to 50% of the dose into the patient before you had to stop because of the reaction, here's where your asparaginase activity level can be really useful. But you have to send it within 3 to 5 days of having administered the dose. And from there, you can use those levels to guide you down the rest of that algorithm as far as helping you to distinguish antibodies or no antibodies. And then if you've got a patient who received 50% or greater of the dose, you can wait a little bit longer to draw those levels 4 to 7 days after the dose, and then follow the same algorithm to determine if there are antibodies present or not. If you have evidence of early clearance by getting a really low asparaginase activity level after administration of 10 or more % of the dose, then that's a patient in whom you would need to switch to an alternative asparaginase preparation, and what we have available currently is, of course, Erwinia asparaginase. If, on the other hand, the patient, despite having a clinical reaction, still has good levels based on the chart below, then that patient can be safely rechallenged, most likely, with PEG asparaginase for subsequent courses. So Elizabeth first raised the suggestion, and our site as well, is using universal premedication for all of our patients before they receive a dose of PEG asparaginase. And the rationale for this, has been percolating through the literature for some time now, but I think really was highlighted in a recent publication by Stacy Cooper, Pat Brown, and colleagues from Johns Hopkins. We know premedication has been used to prevent infusion reactions, and again, that's not really exclusive to PEG asparaginase. A number of other medications, we routinely use premedications before we give. Antibody therapy, other chemotherapy products, blood products, certainly. We know this is incredibly effective at being able to give our patients these medications that can elicit an infusion reaction. Our strategy is to use a combination of antihistamines, so we use famotidine and diphenhydramine. Other sites also incorporate a corticosteroid. We give that medication at least an hour before the patient receives their infusion of PEG asparaginase to ensure enough time for these medications to be at good levels in the system. What I think was important about Stacy and Pat's study, even though it was a single institution approach, was that it really showed that administration of premedications before PEG asparaginase significantly reduced the number of patients needing to switch from PEG asparaginase to Erwinia. They went on to show that this really wasn't masking antibody-mediated hypersensitivity because they followed levels after administration of these pre-medicated doses and found that patients who were pre-medicated were still achieving adequate serum asparaginase activity levels. So this paper was really reassuring and I think transformative to the field, suggesting that universal pre-medication should strongly be considered for patients receiving PEG asparaginase. We first saw these data at ASPHO actually in 2018, and based on that presentation, we switched from not pre-medicating patients to pre-medicating our patients in the summer of 2018. We looked just at sort of rough data in the 6 months before and in the 6 months after implementation of this pre-medication strategy, and very aligned with these data, we dropped our rates of switching from PEG asparaginase to Erwinia from around 20% to around 5%. So it's a huge difference in terms of our Erwinase use, and in terms of clinic time, nursing time, and certainly burden on families. That's made a big difference for us in our center. Now, practices do vary. COG studies do now allow pre-medication, but they don't mandate it. So this isn't universally implemented at all sites. But just based on my discussions with other colleagues, I feel this is by and large used at most institutions. As Elizabeth noted, I think therapeutic drug monitoring with serum asparaginase activity levels should be used in patients who have been pre-medicated to make sure you aren't missing some patients who do have neutralizing antibodies. Great. Okay, so now back to our patient. So after receiving his day 15 consolidation dose, Robert comes into clinic and he's reporting abdominal pain, nausea, and vomiting. Labs are obtained, and it's noted that his amylase and lipase are over 3 times the upper limit of normal. He's sent for an ultrasound, which shows findings that are consistent with acute pancreatitis. Elizabeth, with this type of presentation in this patient, how would you manage?
Yeah, so we would, definitely be concerned about pancreatitis with this symptom constellation. So we would admit him to the hospital, bowel rest, IV hydration, good analgesics, and we would follow really closely. I think it's so hard to predict when someone presents with these symptoms what their clinical course is going to be. So we would certainly follow pancreatic enzymes and clinical symptomatology closely every day. And I think if, his symptoms quickly got better after hospitalization and bowel rest and were less than 3 days in their total duration, and didn't have any progression in any way, we would, for the future, given the importance of PEG asparaginase, would probably re-challenge in the future. What about you?
Yeah, I think we would follow the exact same course for this particular patient. We know that these patients, even if their presentation is initially quite mild, they're still at risk for serious complications. So certainly admission to the hospital with NPO status, and then close monitoring of his clinical status as well as his pancreatic enzymes would be important. As you described, because we know for best possible outcome for this patient, he really needs to get all of his asparaginase courses if that's safely possible, provided he resolves quickly and doesn't have any serious complications of his pancreatitis. Most likely we would choose to re-expose this patient cautiously, but certainly the risk benefit balance would, I think, fall to re-exposure for this particular patient. So pancreatitis is one of the unique toxicity of asparaginase, and as Elizabeth mentioned in the very early goings of this talk, it occurs in about 5 to 10% of our patients. The severity can vary quite widely from asymptomatic elevation of pancreatic enzymes all the way to a severe grade 5 even toxicity that unfortunately results in the patient's death. For a long time, we didn't really have great data because of the relatively uncommon nature of pancreatitis after PEG asparaginase in terms of helping us to understand which patient groups were most at risk for the development of pancreatitis and the severe complications of it. But this great paper published by the Pantaleño group some time ago gave us great level data from multiple consortiums around the world on the incidence and severity of pancreatitis in our patient population. And what they found is that the risk of developing any grade of pancreatitis is greatest in those who are older than 10 years of age. And patients who are older are also at the greatest risk for severe toxicity, including at higher risk for need for mechanical ventilation, acute insulin therapy and the development of pseudocyst, as well as death from their pancreatitis. So certainly our AYA patient here is at a risk for severe toxicity with his pancreatitis. This paper was also incredibly important in, I think, providing information about what happens with re-exposure after an episode of pancreatitis. So a number of those patients with a variety of severities in terms of their presentation were re-exposed to peg asparaginase after their pancreatitis episode. And what this paper really nicely showed is that the incidence of another episode of pancreatitis after re-challenge was about 50%. And interestingly, that really didn't depend upon how severe your initial presentation was. So when they divided those patients up into patients with relatively less severity episodes of pancreatitis versus those with severe episodes of pancreatitis, the incidence of recurrence of pancreatitis was no different, really about 50% for each of those groups of patients. Additionally, the second episode, when it does occur, does not tend to be more severe. So patients who had a second incidence of pancreatitis weren't more likely to have need for prolonged insulin therapy or pseudocysts, for instance. So in general, the risk has to be balanced with the need. For some patients, perhaps that 50% risk of developing pancreatitis again is greater than the potential benefit. So maybe our NCI standard risk patients who are getting their second and last dose of peg asparaginase, perhaps those are patients where that risk-benefit ratio may fall into not re-challenging. For our kids who really need intensified asparaginase therapy, those patients, potentially the balance lies in re-challenging them, taking that 50% risk in mind. COG protocols have considered these data, and we've pretty recently sort of loosened up our language about who is suitable for re-challenge with peg asparaginase after a pancreatitis episode. And currently the COG protocols do allow for a re-challenge in patients who have had grade 3 pancreatitis that is deemed mild. And by that, we mean patients' symptoms have resolved within 72 hours and they haven't had severe complications of their pancreatitis, including no development of a pseudocyst. Now, this doesn't mean that the patients have to have complete resolution of their pancreatic enzyme elevation within that 72-hour period, but all of their symptoms have to have resolved within that amount of time. For these patients, it's left to the discretion of the provider if they re-challenge with asparaginase or not. So I think that loosening of language does allow providers the opportunity to re-expose their patients if they really deem it in their best interest. So going back to our case, so Robert recovers from his episode of pancreatitis, and he had his symptoms were gone within 72 hours. He didn't have any severe complications. So his provider chooses to give him his day 43 of consolidation, peg asparaginase dose, after he was pre-medicated. Appropriately, serum asparaginase activity levels were sent 7 days later, so when he came in for his day 50 visit, and it was found that his level was undetectable. So Elizabeth, what would you do in this situation?
So this patient, unfortunately, Robert has a silent inactivation with an undetectable level at the 7-day mark. So these would be indications to switch to Erwinia asparaginase. We have been fortunate of having availability for the most part, but we've had periods of time where it's not available, and I know many centers across the country and even globally have had really challenges in access to the drug, and right now that's really the only approved alternative in a situation like this. Had it been a hypersensitivity reaction, I think we'll speak a little bit about, desensitization, but in a situation where it's just pure silent inactivation, that's not going to help us so much in that situation. Our center does participate in the JZP COG 1931 protocol, so would have that option for RCP in certain situations. So children with silent inactivation are eligible. But in this situation, if you've had a prior thrombotic event that's required significant anticoagulation, or if you've had pancreatitis, those would be exclusions. So it would really leave us sort of in a challenging situation where Erwinia would be our only alternative in this particular situation. Are there any creative workarounds that you can think of or other ways that you would approach this case at your center?
Unfortunately, not. I think everything is as you laid it out in terms of the situation. So we do also have AL 1931 available. So RCP is an option for our patients, but not for this particular one, given he meets several of the exclusion criteria. So, we have been fortunate over the last several months to have Erwinaze available. So this is a patient for whom we would prioritize allocation of our existing Erwinia supply to, for sure. So no easy answers, but in this case, I think that's the only option for him, unfortunately. So just a bit of brief information on silent inactivation. So just as Elizabeth said, this patient meets the criteria to be classified as having silent inactivation. So that's defined as having no clinical manifestation. So he didn't have any clinical allergic type symptoms at the time he was given the medication. However, based on the serum asparagine activity level being undetectable, it's very clear that he's had a rapid immune-mediated asparaginase destruction. And of course, if you've destroyed your asparaginase, it can't possibly be effective. So this leads to loss of therapeutic effect. The incidence estimates vary, but most studies will show it's in the single-digit range, so 2 to 10% is what's been documented. And based on good COG data, that's about what we would expect with our patient population. Now, how do we use our serum asparagine activity level to identify silent inactivation? Meaning, what's the level that sort of you need to have, and at what time point after getting the dose should you use to determine if a patient has silent inactivation? And fortunately, we have excellent PK data from a number of studies, dating back several years, that show us what a patient without neutralizing antibodies should do in terms of their serum asparaginase activity over time after receiving an asparaginase dose. So based on these robust data, we've been able to develop some guidance to help physicians determine what to do with those serum asparaginase activity levels when they get them back, dependent upon how long has passed between the time the dose was administered and when you drew your levels. So this is the guidance that's currently in COG protocols to help providers identify silent inactivation when it occurs. And again, this is based on a lot of PK data in patients who have received PEG asparaginase. For us personally, because our patients at the time in therapy when they're getting PEG asparaginase are usually coming back on a weekly schedule, we'll send it off 7 days after they've received the dose. And so for those patients, you would anticipate them having levels of at least 0.3 or greater. If it's less than that, that's really, that indicates that the patient has developed silent inactivation. Elizabeth, when do you send your levels in patients in your clinic?
We typically, the 7-day mark, we always try to make sure it coincides with a clinic visit for, patient ease as well. And it seems like just with the schedule of when PEG asparaginase is due, it usually is a 7-day mark, but 7 to 14 is our practice. Sounds like it's nearly identical to yours.
Mm-hmm. Yes, I think most centers would hopefully be able to accommodate when the patient's already coming into clinic to grab those levels, but I know practices do vary. Okay. So, of course, the standard management of hypersensitivity, so in patients who have evidence of antibody-mediated clearance of their asparaginase, they really warrant a different preparation of asparaginase. And because there's no cross-reactivity between the asparaginase produced by an E. coli bacteria and the asparaginase produced by an Erwinia bacteria, you can safely substitute the Erwinia asparaginase for E. coli asparaginase. And so the indications to switch from PEG asparaginase to Erwinia asparaginase is definitive severe allergic reaction. So a patient with angioedema, respiratory symptoms, and otherwise pretty clear-cut anaphylactic reaction to their PEG asparaginase warrant a switch to Erwinia. Patients like the one that we're describing here who have evidence of silent inactivation or who have inactivation post their premedications also warrant a switch to Erwinia. And then if you have a patient who's had sort of that plus or minus a questionable reaction, but you've sent off your serum asparaginase activity level and it does confirm early clearance of the drug, those are also patients for whom an alternative preparation is necessary. This is just the standard COG dosing for Erwinia for patients who need to switch from PEG asparaginase. So we prescribe 2,500 international units per meter square, given either IM or IV on a Monday, Wednesday, Friday schedule for 6 doses to replace each dose of PEG asparaginase the patient was due for. Elizabeth very nicely highlighted the fact that we've all been prone to Erwinia shortages over the last several years. Elizabeth, what's your strategy if you don't have Erwinia available at your site?
Yeah, it's tough. I mean, I think we find that centers in the area are willing to help each other out, just given the importance of getting the true course of asparaginase for each child. So we'll look to other centers in our area. Again, the RCP option, we've been very grateful to have offer protocol enrollment, but in this situation that we would have been limited in this case. We have a priority scheme sort of institutionally, and pediatric patients are prioritized, and certainly among those pediatric patients, an AYA patient with high-risk disease, a Philadelphia-like signature would be, definitely a priority patient in our site.
Yeah, that's certainly the same for us, and it's been unfortunate that we've had to sort of make these types of drug allocation decisions, but we similarly would prioritize such a patient to get the Erwinia that we do have available. We mentioned briefly the strategy of desensitization. Now, this is not intended for those with silent inactivation, but those who have had a clinical reaction for whom that would normally prompt a switch to Erwinia, but you don't have Erwinia available to you. And a number of institutions have published their experience with this strategy. Essentially, you just start with a very dilute preparation of pegasparaginase and then slowly administer it and then titrate up the concentration of the asparaginase as tolerated. Typically, this is done in an ICU setting. It takes an extreme amount of time and certainly a lot of clinical resources, but can be effective. There have been these studies here, as well as a few others, that have reported up to 70% of patients will be successfully re-challenged with this strategy. So certainly worth consideration if you're in a situation in which you have a patient who really needs asparaginase therapy, you don't have Erwinia, and perhaps they aren't eligible for the JZP study. This would be a strategy that could be considered as well. So we've described this new preparation of asparaginase, JZP458, which we call RCP because it's easier to remember. RCP is, as Elizabeth described, is a recombinant chrysanthespase. So it's the same amino acid sequence as Erwinia, but it's produced in a different vector. It's produced in Pseudomonas fluorescens. Just like Erwinia, it isn't cross-reactive with E. coli-derived asparaginases, so it can be safely substituted in patients who have had hypersensitivity reactions. RCP is intended for use in patients who have had reactions to E. coli-derived asparaginases, and that's the population in which it's currently being studied. Jazz conducted, before they initiated their pediatric clinical trial, they conducted a phase 1 healthy volunteer adult study. And this is just data from that publication showing that the pharmacokinetic profile of JZP458, when administered either via IM route or IV route of administration, really overlaps with Erwinase, which would be expected since they're essentially the same protein structure. And this just shows at the 72-hour time point, the serum asparaginase activity levels in those who received Erwinia compared to those who received JZP were almost identical, suggesting that really these drugs behave exactly the same way in vivo. And this is just a table from that same study comparing IV routes of administration of either Erwinia in the gray box to JZP on the left, showing that all the patients achieved greater than or equal to 0.1 units per mil, which defines the therapeutic threshold for serum asparaginase activity levels at both the 48 and 72 hours, and likewise for those who received it via intramuscular route, highlighted in red. They also looked at a slightly higher level, 0.4, and found that a number of patients did achieve that at 72 hours, but those relatively low percentages of patients achieving that level were similar between Erwinase and JZP. So again, all supporting the fact that these two products behave much the same in patients. So AALL 1931/JZP458201 is a Jazz industry-sponsored trial jointly run with the Children's Oncology Group. And just very briefly about the trial, it is an open-label, multi-center study with dose confirmation by pharmacokinetic monitoring by serum asparaginase activity levels. It is open to newly diagnosed patients with ALL or lymphoblastic lymphoma who have developed hypersensitivity to an E. coli-derived asparaginase. It's open to children and adults, but not open to relapse patients. So that's an important consideration as well in terms of eligibility. It's a two-part study, initially studying the IM route of administration, and then Part B studying the IV route of administration. The IM part explored multiple dosing strategies and is now closed to accrual, with data currently being reviewed by the FDA. The IV route of administration being investigated in Part B is currently enrolling patients at a very nice pace. So to conclude, just a few take-home points on asparaginase use in pediatric ALL. Asparaginase is certainly a critical component of our therapy for ALL and lymphoblastic lymphoma patients. The unique toxicity profile leaves us with some challenging clinical situations with which we have to manage. Hypersensitivity is one of those unique toxicities. It's relatively common in our patients receiving E. coli PEG asparaginase, and therefore alternative asparaginase availability is really critical to maintain those outcomes for our patients. With that, I'll close and turn it over to Elizabeth. I think we have received some questions.
So we appreciate everyone's attention, and we really received some excellent questions, so we wanted to take a few moments to address some of those. So one of the questions is do you ever encounter early hypersensitivity to PEG asparaginase, i.e. in the very early stages of therapy? So Rachel, what are your thoughts about that?
Yeah, I think as we outlined, it's most commonly encountered actually with those second or third doses, and very rarely we'll even have a patient who with their very first dose of asparaginase has a reaction that prompts a need for an alternative asparaginase product. Again, I think you have to sort of weigh the risk factors of the patient. So if this is a patient at high risk for relapse, an AYA patient, a patient with pH positive or pH-like disease, those patients you would really want to prioritize getting them an asparaginase preparation, be that Erwinase or RCP if available to you. How about you, Elizabeth?
We would really, I would think similarly about that. It really is quite rare in induction to have a hypersensitivity reaction. So I would lean towards, making the assumption that it's likely to be an infusion reaction, watching the patient very carefully and seeing if we could get the medication in. If it's a second or third dose, those, as you showed, those are the statistically most likely times to see the reaction. So I would, be more concerned about hypersensitivity in those types of situations.
Yeah. So we've already discussed premedication, and there are a number of questions around that. So I think I'll move to a question that asks, if we don't have access to clinical trials, what do you suggest for addressing or overcoming Erwinia shortages and managing our patients? It's a great question.
Yeah. I think this one is, certainly challenging. We touched upon this. I think, certainly in areas where there are several centers in a region, we found that people are willing to help each other out. I think, certainly the data on desensitization has been compelling. It's not easy to do that. It requires a lot of ICU manpower, but, I think, compelling that about 70% of individuals with desensitization can actually get PEG asparaginase doses in and achieve therapeutic levels. So I think that's another option. And I think, too, people have gotten creative about thinking, if there's a dose in interim maintenance 2, for example, could you have a strategy where you consolidate it and look to older dosing protocols and maybe got 1 dose in rather than the 6 doses. While not ideal, I think these are some, unfortunately, of the decisions people are having to make. Yeah. Rachel, any other thoughts?
No, I agree with everything you said. Hopefully the data will look good for RCP, and ultimately that will be an alternative preparation that's more readily available. But at this time, we're still sort of left being creative, unfortunately. So going on to another great question, what pre-existing conditions, comorbidities should give one pause when using pediatric protocols? I think we've discussed the risk of our AYA population for liver toxicity, pancreatitis, and potentially other of the more severe toxicity of asparaginase. I think one strategy would be consideration of dose capping, particularly for our obese patients. I think that it's shown in adult studies as well as in at least one pediatric institutional study efficacy in terms of reducing toxicity. But those are the patients we get most worried about when dosing with Peg-asparaginase for sure. I don't know if Elizabeth, you have other thoughts to add.
No, I think that I would think of it very similarly. I think we have a question that's timely. Have you been delaying induction consolidation protocols due to COVID? Or if you did earlier, are you back to normal now? I think, this is a great question. I think we've been fortunate to, be at a time where we're seeing less of these infections now, but certainly a year ago, this was, really a very, very relevant question. And we were initially concerned. I think there are a couple ways of looking at it. I mean, now we have some reassuring data that most children, even while on active therapy, who develop COVID infections, fortunately do really pretty well. I think when you have someone in induction, it's so critical to really treat their leukemia so that they can recover their immune system and be able to address the infection appropriately. So in most situations, we haven't delayed and we've gone ahead with induction. Sometimes there have been some reports in the literature of very fulminant presentations of COVID patients in the ICU where there has been more concern about the tolerability of intensive chemotherapy. And there was a nice report that where a patient was managed initially with several days of corticosteroids and blast count came down, infection improved, and then was able to start a full induction regimen. But I think, they're nuanced decisions, but that's sort of been the approach that we've taken and fortunately have not had to interrupt a lot of therapy. Rachel, what's your experience been?
Yeah, similarly, we were really, I think, in the heat of it last summer, and we had a number of patients who were testing positive. Luckily, most of those patients were asymptomatic, and so for our asymptomatic yet COVID-positive patients, we weren't really preemptively interrupting their therapy. Of course, we had a few patients who were critically ill with COVID, requiring ICU admission, and inevitably you have to pause therapy for patients dealing with a very severe complication of that illness. But for the vast majority of our patients who have been COVID positive, their symptom profile is mild enough that we're able to proceed with therapy because we know it's such of critical importance, particularly early on in treatment, to stay on track with their therapeutic regimen. So that's been our general approach. I think those are all the questions that we appreciate some really good discussion and thoughts. And I think with that we can close.
Well, on behalf of Rachel and myself, we'd really like to thank everybody for joining today and for the excellent questions that you've submitted. Thank you so much.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ZBG860. This activity is supported by an educational grant from Jazz Pharmaceuticals Incorporated. This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.